just want to introduce Gill Lowe. He's a consultant haematologist from Birmingham. I'll let her introduce herself formally, but she's going to talk today about MAHA in pregnancy. So I'll just hand over to Gill, and thanks for joining us.
No problem. Thanks for asking me to speak. Good morning, everyone, or I guess good afternoon, possibly. So please feel free to sort of discuss things as we're going with this. I will stop and ask questions at some points, more because I'm recovering from a lost voice, as you can hear. So I'll need to pause to give my voice a little bit of time to recover when we're between slides. So I'm a consultant haematologist in Birmingham, which is a big city in the UK. We have a large population and extended population in the areas around Birmingham. And as part of my role, I do obstetric haematology for the city itself and for a maternal medicine network that we have for the region. So what I'm going to talk about today is presentation of MAHA, which is Microangiopathic Haemolytic Anemia in pregnancy. And I'm going to use some recent cases from on-calls over the last few months to illustrate that. And hopefully try and contextualize things as we're going through. There are some rarer things that I've included more just for interest and for discussion. And we can see what else you think as we're going and whether there's anything else that you want to check. So let me just share my screen. Just bear with me while I do that. Hopefully that is sharing now. Can I just check that you can see that, please?
Yeah, we can see. Thanks.
Brilliant. Thank you very much. So just some declarations there in terms of previous educational sessions that I've done, and to say that I work as part of a TTP Specialist Commission Centre in the UK, and I'll talk a little bit about that system as we go through. So I want to talk a little bit about MAHA, or thrombotic microangiopathy in pregnancy, with a focus on TTP. We'll talk about some recent cases. And then I'll talk a little bit about the end about other scenarios where you might get thrombosis with thrombocytopenia, which is quite an unusual clinical presentation. But when you do see it, there are a certain number of things to think about in terms of urgent treatment and next steps. And hopefully plenty of time for questions and answers as we go. So in terms of what is MAHA first, I think it's a condition that does cause a lot of confusion, but essentially what happens is you get low platelet counts and red cell fragmentation on a blood film. So you can see on this picture, which is just representative, that there are lots of red cell fragments, and that happens when the red cells are churned up because they're passed through fibrin meshes in small blood vessels. So the combination of the morphological finding in combination with a thrombocytopenia is what points you towards there being a MAHA present and would prompt you to think about it and consider further investigations. When you see it, there are certain things that you would start thinking about. And obviously in this scenario, you need to know more about the patient's clinical history to point you in the right direction. So very rarely we see some congenital disorders that can present like this. So an inherited deficiency of ADAMTS13, which is the enzyme that causes TTP, could cause this, or some inherited complement gene variants. Obviously these conditions are extremely rare. Most of the time it is an acquired problem and it's an immune problem. And we would think then about autoimmunity with TTP or atypical hemolytic uremic syndrome, which is an autoantibody against part of the complement cascade. And then probably more commonly, actually, we would sometimes see this picture with infection or as part of DIC. So particular conditions in which you might see it with infection would be Shiga toxin producing E. coli causing hemolytic uremic syndrome or HIV associated MAHA. And then in terms of secondary causes of this kind of appearance, there's a big list here, and lots of these are relevant in pregnancy. So we definitely do see this picture in people who have significant preeclampsia, where they will drop their platelets often towards the end of pregnancy and get fragmentation, also with malignant hypertension or an association with an actual malignancy or cancer itself. And then various other conditions listed there, including DIC, which I mentioned before. And we sometimes see this as a complication of antiphospholipid syndrome as a catastrophic variant of that, and rarely due to certain drugs. So there's a broad differential when you see this picture, and like everything that we do, the clinical situation is by far the most important thing in deciding where you go next. I'll just pause for a second now. Does anyone comment on whether you've seen cases like this or whether you have any questions so far? Has anyone seen the combination of the low platelets and the red cell fragmentation in pregnancy at any point? I'm just checking chat just to see if anybody's typing responses as well. Okay, I'll carry on. But I think for most obstetricians, this is a situation you would usually have come across. I appreciate getting blood films may not be the easiest thing to do, so that part of the diagnosis may be more of a challenge. So thinking of other causes of why you might get thrombocytopenia and red cell variation on a blood film, there are some commoner causes. So I'm always very conscious of the need to exclude hematinic, including B12 and folate deficiency as a cause, liver disease. Sometimes inherited thrombocytopenia would give you part of this picture, although that wouldn't normally cause the red cell changes. And then sometimes pseudo thrombocytopenia, where you get platelet clumping, again could give the platelet count changes, but usually not the red cell changes. Similarly with type 2B von Willebrand disease. And then finally, the thrombocytopenia might be because of autoimmunity to PF4, which gives you a HIT or a VIT-like picture. And malaria as well as a common cause of thrombocytopenia in relation to infection. So I've just got a couple of screenshots now about looking at TMA in pregnancy and looking at thrombocytopenia in pregnancy. Thinking of TMA or MAHA, so those two terms would be synonymous. In pregnancy, the timing of the onset helps you to work out what kind of syndrome or clinical diagnosis this might be. So presentation early would go more towards TTP or HUS, and presentation later in pregnancy would be more in keeping with PET or HELP as an underlying cause. And then in terms of differentiating these diagnoses, I have to say I find this very, very difficult in clinical practice. So there are tables like this that will look at incidence. Obviously, we know that preeclampsia is a very common condition in pregnancy, and some of these other diagnoses are much rarer. And this looks at things like degree of renal impairment, degree of thrombocytopenia, presence of neurological features to help you to differentiate. But in reality, my own opinion is that these conditions are a spectrum, and it's actually very hard when you get the first information to decide exactly which diagnosis this is. And the most important thing at that stage is to keep general management principles in mind and then work your way through other tests that might help you give a more specific diagnosis. So in this table, it talks about measuring an enzyme called ADAMTS13, which is what is deficient in TTP. And that obviously would help you in making that specific diagnosis. Can I just ask if anybody's able to speak or type on chat whether you are able to access ADAMTS13 testing when you're considering TTP as a diagnosis? If you're able to either take yourself off mute and let me know or put a comment on chat, that would be great. Okay.
Good afternoon, Dr. Lowe.
Oh, hi.
Yes, so I think that the time that Dr. Swallow came through, we had mentioned, so the challenge that we usually have sometimes is the issue of investigation. So sometimes even if you are thinking towards a specific diagnosis, you find that you can't investigate, either the patient can't afford or the public service system doesn't have the reagents for those specific tests. So ADAMTS, is it TS13? We rarely do it because of that issue of the reagent.
And if a patient did have funds to do it, would you be able to access the test? Is it mostly the funding that's the issue rather than the actual ability to do it with the funding in place? Is that right?
So when the funding is in place, like for those that can afford in private settings, we have a number of private labs that sometimes even send samples to India. So you get a number of tests that we are not able to do locally.
Okay, yeah, thank you. That's helpful for me to know. It makes me realise how fortunate we are in the NHS, despite its deficiencies. And I appreciate some of the things that I'll say will not be as easy for you in terms of accessing investigations. So feel free to sort of update me on that as we're going. So just moving
Then I
on.
wanted to ask, sorry.
No, go on.
You
Go ahead.
You had mentioned the fragmentation of the red cells. So in terms of suspicion, when we just have a bicytopenia of low hemoglobin levels and low platelets, we should be thinking of MAHA, or there are more hematological tests that we need to do as opposed to just basing it on the hemoglobin level.
So we'll come on a little bit to other tests that we can think of later, but that's a good question. How easy is it for you to get blood films done?
We have a hematology lab that does that, but sometimes they have a lot of samples to process. So you find if you request for a smear, they will take some time before the results come out because of that backlog that they usually have.
Yeah. So I think in the presence of a bicytopenia, it is something to think about, definitely with anemia and thrombocytopenia, but obviously there are many for that in pregnancy. So I would have it in your differential, but I think in that situation, the things that I would do next, if you can do it, would be a blood film. And the other thing that I find a helpful initial test is doing LDH. So having something that gives you a marker of whether there's hemolysis or reticulocytes or bilirubin, anything else that implies that there may be active hemolysis would then point me more down the MAHA or TMA line.
Thank you so much.
No problem. We'll carry on, but feel free to keep stopping. I do apologise about my voice. I've been hoping since Sunday that it was going to recover enough for me to be able to do this. So if we think a bit more generally about thrombocytopenia in pregnancy, this slide is from a really good review about that condition, about low platelets in pregnancy. And essentially, this is just giving you a flavour, but it goes through the fact that the majority of thrombocytopenia in pregnancy is gestational, but there are other important causes that need to be considered. And again, the gestation of presentation of the thrombocytopenia sometimes helps you to work out what it might be. And I like this figure, which looks at different stages of pregnancy and looks at all platelet counts. And if you have thrombocytopenia, what it's more likely to be. So you can see that women who have thrombocytopenia in the first trimester, a large proportion of them will have ITP, which may be pre-existing before pregnancy. But then as you move further through pregnancy, many more people have gestational thrombocytopenia. And in the third trimester with very low platelet counts, that often relates to preeclampsia. So I think this is a useful way of thinking about if you see a low platelet count at a particular gestation, just on balance of risk, which of these conditions it's more likely to be. So I'm just going to tell you about a few cases now, and then we'll come back to talking about these conditions more generally. So this first case is a very sad case. It's from 5 years ago now, but I still remember this case extremely clearly. So for us at this particular time, this was right at the height of the COVID pandemic in the UK. So we had the first wave in March 2020. And then after that first Christmas, we had a significant increase in cases. So at this point, we were really struggling. Our clinical team were working on ITU and doing shifts there because of capacity issues there. And we weren't always doing our regular clinic appointments, just to give you some context. So this was a lady who was aged 36 and was 26 weeks pregnant. She'd had one previous baby and one pregnant. And she'd been diagnosed with TTP in 2018, which was after her first delivery. So this was the first pregnancy after the TTP diagnosis. She'd done very well with her TTP treatment and her ADAMTS13, which we are able to monitor, completely stable. But once she got pregnant, we did start to see some low values. And that is a normal phenomenon, that a woman who's been stable but then becomes pregnant often will slightly drop their ADAMTS13 value when they're pregnant. BWH here stands for Birmingham Women's Hospital, which is the regional centre that I work at. So she came for a one-off visit to the Women's Hospital, and we did her ADAMTS 13 at that visit, and it was normal. And I very clearly remember talking to her about transferring her care to the regional centre, but she didn't want to do that because it was quite a long way for her, and she had some issues with her family. Her dad had been diagnosed with cancer, and so she wanted to be closer to home. So we spoke to the haematologist in her local unit, who's a very close colleague, someone we work with very well. And we agreed to ongoing monitoring. We said that if her ADAMTS 13 dropped further, we would consider giving her immunosuppression like cyclosporin with appropriate monitoring. And then we agreed that empirically we would deliver her at 38 weeks, really because of a concern about the chance of TTP relapse increasing as you get closer to term and von Willebrand levels increase. So when she was 30 weeks, she went for an assessment in her local obstetric unit because they thought she might have a perinephric abscess. She hadn't been very well and had some other findings on initial imaging that suggested that. And when she was there, she collapsed in the department. And the first phone call I got was to say she's had this collapse and her platelets are 14. We've run them urgently. Unfortunately, the baby had died, so the team already knew that. They'd listened to the fetal heart and diagnosed that. And she did have initial coagulation testing, which was normal. So my immediate thought was that this was a relapse of her TTP based on that low platelet count and what I knew about her clinical history. And I asked for them to give her steroids and some FFP in that local hospital while we tried to get her over, because I knew that moving her to an ITU at our centre was going to be very, very difficult because of the COVID issues. Me and another consultant colleague then started phoning our ITU colleagues and actually phoning other hospitals in the region as well. And it did take us quite a long time, even with two of us doing that, to get her transfer arranged, and then there was a delay with the ambulance. So now for patients with TTP, whether they're pregnant or not, they come straight to our ITU on an urgent pathway, and that works much, much better. Just before she got in the ambulance, she had a fit. And in people with TTP, fits make me really worry, because what that's telling you is that there's a problem with microthrombosis in the cerebral vessels. And she arrived at our hospital about 6 hours after that first phone call. Just before she arrived, she had a cardiac arrest in the ambulance. And then one of my ED colleagues delivered the baby in ED to see if offloading the pressure on her veins would improve their ability to resuscitate her. Unfortunately, that wasn't the case, and this lady died. And her ADAMTS 13 level after she died was confirmed to be low. So this was a relapse of her TTP. And in the UK, when a pregnant woman dies or a woman within a year of pregnancy, there's a national governance process review called HSIB, which looks at the circumstances around the death and tries to identify learning points. And so this lady's case was reviewed at HSIB. Her family were involved in that process. I was interviewed, and many of my other colleagues were. The outcomes from that were sort of communicated in terms of development of a TTP pathway. But I always remember this lady, you know, when I'm talking about TTP in pregnancy, in terms of how fragile a condition it can be and how we do need to act really quickly. Fortunately, this is a rare event, and, you know, most of our cases do have good outcomes, but I'll tell you about some of this now as well. Does anyone have any questions about that before I move on to the next one? Has anyone seen any similar presentations of maternal deaths in the presence of thrombocytopenia late in pregnancy?
Hello, good afternoon.
Hello, hi.
Hello, Dr. Chira is my name, from Women and Newborn Hospital.
Nice to meet you, thank you.
Thank you. So we had a similar case to what you have described. Fortunately, ours delivered, but died within, I think, 12 days of delivery. Very similar presentation. we were not able to carry out much of the investigations. By the time we were delivering her, her HB was at about 6 and her platelet count was very low at about 3.
Yeah, so that would be, suspicious, wouldn't it? And these women do go off very, very quickly. So even when we have access to all the relevant testing and the treatments, we have a very narrow window of opportunity in which we can get on with the treatment that we need to give. But if I move on to the next cases, then hopefully there'll be some of the things that come up with them.
I did have a question, sorry. I wanted to find out, based on the cases that we've had at Women and Newborn, I've noticed that most of them tend to do badly after delivery. Is there any particular reason why? Thank you.
Yeah, good question. So I think I agree with you that the postnatal period is the highest risk for decompensation. I think that's because that's the time when von Willebrand levels naturally will significantly rise as part of the, evolutionary process to reduce the chance of postpartum hemorrhage. And if you have TTP or MAHA, an increase in the VW levels can make that process worse. So that's my interpretation of why the immediate postnatal period is so risky. I think the other thing is that women who are immediately postnatal, often people won't think necessarily of these things. We definitely see that in the UK. In this next case, there's an element of that as well. So it's more thinking of the diagnosis as well. Sometimes in the UK, if women haven't had risks in the antenatal period, the postnatal process is managed as quite a low risk process, on midwifery-led wards where women wouldn't necessarily see a doctor. So if somebody starts to become more unwell, it can take a little while to pick up on that. Okay, let me move on to the next one and then hopefully we can have some more discussion there. So this next case is quite a recent one. I've just seen this lady for follow-up within the last couple of weeks. So she's 35 and she was 5 days postnatal. She'd had her first baby by an emergency cesarean section because of fetal distress after induction. And she'd been noted to be hypertensive in labour, but she hadn't had any hypertension before that. She'd had some proteinuria with her community midwife at around 36 weeks, and she had some headaches then, but her BP was normal. So that was just monitored at that stage. So then the team who were looking after her noticed that she was starting to become jaundiced in the immediate postnatal period. And they said maybe she's had help because of the fact that she was hypertensive in labour. The baby was doing well and was mixed feeding. And her past medical history was that she had Sjögren's disease. She was anti-Ro antibody positive, which can have an impact on fetal heart rate. So throughout pregnancy, she'd been having fetal heart rate auscultation, which had been okay. And this was the indication for her induction of labour. Her platelets were 25. This is the point at which I got phoned, and we did have her LDH available, which was very high. And so the phone call to me was to say, we've got this lady, her platelets are low, she's got a few red cell fragments on her film, her LDH is high, and we also knew that her troponin was raised. And a bit like people with TTP having fits, having a raised troponin tells you that there is microthrombosis within the coronary blood vessels, and that is an end organ effect of the TTP. So we went on to confirm that this lady did have TTP and she had a positive inhibitor assay. So what that tells us is that this isn't congenital TTP, it's autoimmune, but that result takes a little while to come back. So her initial treatment was plasma exchange, steroids, folic acid and caplacizumab. And I'll come on to talk about caplacizumab in a bit. Unfortunately, she reacted to rituximab, which we give for CD20 suppression. So she went on to have an alternative agent. And the normalization of her ADAMTS13 level took over 6 weeks after giving her that treatment. So we've been monitoring her closely and letting her know when she can stop her caplacizumab. Her troponin's normal now, which is good. And she's had an MRI of her head, which was normal. And she's had excellent input from our specialist psychology team. So I appreciate we're in a very fortunate position to have this service. But one of the things that we know with TTP is that as we get better at treating the initial part of it, sorry, just excuse me. Just bear with me. I will just let this person know that I will phone them back. Okay, sorry about that. So one of the things we know with long-term survivorship is that people do get quite bad neuropsychiatric or neuropsychological consequences. So the involvement of specialist psychologists makes a big difference in that. And especially for this lady who was separated from her baby for quite a long time around her admission, thinking about that and how she can cope with that going forward is a big part of her care. The next case, also a very recent one, is a lady who's 37. So she had had 3 previous pregnancies, but quite a long pregnancy interval. And she presented with nosebleeds, and she'd been vomiting and had some streaks of blood, had a headache and some blurred vision. And she'd been having treatment for dyspepsia. So she was found to have blood and protein on urinalysis, but had no past medical history outside of pregnancy, and had a thrombocytopenia with red cell fragments on a blood film. She was confirmed to have TTP. She was about 17 weeks pregnant at this stage, which is a difficult gestation for this diagnosis. So she'd had a 12-week scan where there were no concerns. When she came to our ITU, I asked my obstetric colleague if they would scan her just to check that nothing had changed, and there were no concerns on that initial scan when she arrived to ITU. So we had a lot of discussions about her and whether we should give her caplacizumab, because that drug is not licensed in pregnancy. So on balance of risk, because what we needed to do was to optimize maternal health for the sake of the baby, we did decide to do it. This lady actually presented on a Saturday when I was on to support one of my more junior colleagues, and I phoned our maternal medicine network lead, who's my friend and a good long-term colleague, to make this decision because I felt it needed that level of seniority. So we did give her the caplacizumab. The risks of caplacizumab are that it increases bleeding because it stops von Willebrand factor binding to platelets. So the main risk is the bleeding complications. But really what it does is it gives you an acquired form of von Willebrand disease. And obviously we do look after women with von Willebrand disease in pregnancy. Sorry, please just bear with me 1 second. Sorry, ironically, I'm getting calls about a possible new case of TTP. You couldn't make this up, could you? While I'm doing this session, but I do apologise. So this lady did have caplacizumab, and we decided that based on maternal health needs. She recovered her platelet count quickly and recovered her ADAMTS13 levels, and she had a similar combination of treatment to the lady that I've just described. She was then noted to be hypertensive, and started labetalol first and then went on to nifedipine because her BP wasn't controlled on initial labetalol, and she had a raised ACR that was improving but still not normal at 48 hours after the first one. And then unfortunately, as she got to 19 weeks, she had ongoing hypertension and placental abnormalities on a follow-up ultrasound, and the baby was felt to be very small at this stage. And essentially, my obstetric colleagues felt that the pregnancy was non-viable and that the degree of her hypertension meant that we needed to consider medically terminating the pregnancy. And so there was a lot of discussion with her and her husband about that. And she ultimately went on to have a medical termination at 19 weeks because of maternal health and non-viability. So I'm following her up at the moment. In terms of her physical health, she's doing well. She's finished her rituximab and has a normal ADAMTS13. She's having input from our psychologists. And I've also been in touch with my colleagues who run the complex contraception service to talk about ongoing contraceptive options, because in this situation, I definitely would advise a woman to avoid a pregnancy for at least 12 months after an acute presentation of TTP until we know that there is some stability. and that we know that we've monitored ADAMTS13 levels and they're okay. And then at that point, if a woman does desire another pregnancy, we can think about how we would support that and what treatment we would give if there were any concerns. I'll just pause at that point. Does anyone have any questions or comments about those cases? Okay, that's fine. I'll carry on. Okay. So if we think about TTP, we've talked about lots of this information already. It's a process where there's occlusion of the small blood vessels and the end organ damage happens because of that process. Usually the sites where that causes issues is in the heart, the brain, sometimes the kidney. That sometimes explains the problems with proteinuria, hypertension, and changes in renal function. But the ultimate cause of death in patients who die is usually this process happening in the heart and causing myocardial ischemia. This is an acute hematological emergency. And when we think of what happens in people who with TTP, ADAMTS13 is normally an enzyme that chops up von Willebrand factor multimers. So by doing that, it trims it and it stops small blood vessels being occluded by blood clots. When you lose ADAMTS13, you get big strands of von Willebrand factor that bind to platelets, and then they occlude the small blood vessels. And the blood film picture that you would see is typically like this, where there's red cell fragmentation and abnormal red cell appearances along with thrombocytopenia.
What do you have for breakfast?
What I would say about this is that sometimes early in the disease, you don't see very much in terms of red cell fragmentation. So it can sometimes take a little while for the fragments to appear, so that only having a few fragments wouldn't put me off the diagnosis if there were other suggestive features. And it's a rare disorder. We estimate the incidence to be about 2 to 6 patients per million. But if we don't treat it, we know the mortality is very, very high. If we give treatment, it still has a significant mortality, but much improved. There's no ethnic predisposition. That's important because we know that this presentation can happen anywhere. And actually, there is some data that suggests that people of Black ethnicity have worse outcomes with TTP, even when they're treated within systems with good access to investigations and treatment. So that's something that's got separate focus in terms of why that might be. We know that more women than men get this condition and that the median age of presentation in adults is around 40. So presentation typically is felt to be very acute, but we do see some people where symptoms have been developing over a slightly longer time. People might have symptoms from the cytopenias like bruising, and often people will have neurological dysfunction because of the problem that's happening within the blood vessels in the brain. Historically, fever was counted as part of the symptomatology, but we know that that's not a reliable feature now. And sometimes people will also have abdominal pain, again, because of ischemia in the abdominal blood vessels. The initial investigations we would recommend are listed here. So we've talked about lots of these already: film, reticulocyte count, and LDH. And then there are other things to exclude other causes, and then to look at the degree of the end organ damage, like the troponin. I don't know, looking at that list, how many of those things you feel that you would be able to access. Which of those tests do you think you would be able to get to? Are you able to do coagulation screens, for example? Is that something that you can access?
Yes, it is accessible, but most of the times it's through these private laboratories and the government system.
And what about troponin?
It's the same. I think it's difficult to get sometimes because they run out of reagents because of the traffic that comes to the government facility.
And when you send samples to the private hospital, what's the turnaround time for getting those results back usually?
There are some tests that are done within. So for those ones, usually within hours or even a day, you get the results. But the ones that they don't have reagents where they send to India, it takes some days before we have the results.
Yeah, okay. So then if we think about the treatment that we give once we suspect TTP, the first part of treatment is plasma exchange. So this involves putting a VAS cath in, removing the patient's plasma, centrifuging it, and then returning it with transfused plasma. And essentially what you're trying to do there is to clean the plasma and to remove the autoantibody. And by giving the plasma back, so we use solvent detergent plasma or Octaplas as the plasma for that plasma exchange, and that contains some normal ADAMTS13 as well, so it replaces the enzyme that's been lost. We don't give these patients platelets because giving the platelet transfusion by giving the platelets antigen and load can make this process worse. And then we give steroids, folic acid, rituximab and caplacizumab. And caplacizumab is just explained here. So I mentioned before that it stops platelets binding to von Willebrand factor. You can see the red Pac-Mans represent that process being interrupted. And we know that when we give this medication, so the first dose is given intravenously, and then after that it's subcut, and giving that makes the thrombocytopenia resolve more quickly and prevents end organ damage. And there's good data from studies on the impact that this medication has. And then hopefully if we get a patient who gets through that initial treatment period well, we go on to monitor ADAMTS13, usually 3 monthly when they're stable. We monitor for the effects of any end organ damage, but my experience is that if people have prompt treatment, that is normally reversible. And then we look for any neurocognitive and psychological sequelae. So in the UK, about 6 or 7 years ago, there was a move to commission TTP care, and we now have a number of specialist centres. And the reason that we did this is that we had very high mortality rates in some regions, including the region that I work in, from TTP previously. This was a condition that not all hospitals saw frequently, and transferring patients, as I mentioned in that first case, was very difficult. So there was a big need to try and help this and try and even things up. And the new service that we've got, the main aim was to reduce the risk of death from acute TTP, but also to reduce the risk of relapse by appropriate monitoring and give better aftercare. And it has been a really helpful and useful process to introduce this system. So this is just looking at our individual hospitals' performance. So if we look at the 2023 to 2024 year, our centre had 15 acute admissions. This was both pregnant and non-pregnant, so all TTP patients. And we have about 100 patients who we have under follow-up who've had previous TTP. And if we look at the time from arrival to starting plasma exchange, over time that has reduced. It's still not perfect, and we're still trying to get that better. But we normally get plasma exchange started fairly promptly now after somebody arrives in the trust. In 3 years since we've had this new process, we've had 3 deaths. So we do still see some deaths. Unfortunately, that's inevitable, but they have reduced. So just thinking a bit more broadly about MAHA in pregnancy, I think thinking about it in somebody who's got anemia and thrombocytopenia, any evidence of thrombosis or microthrombosis is important. And we've talked a little bit about other things that might point you in the right direction in terms of markers of hemolysis. And then early suspicion for TTP is really important. Some of the advice on this slide relates to the setup in the UK about having access to a 24/7 service when you think about it. But some of it is relevant wherever you work. So the point about most patients presenting to an emergency department or acute medical unit, I guess, is probably the same, that they often won't present directly to a haematologist first. So thinking about the diagnosis is the most important part. So just the final case, this is a slightly different scenario. So this lady didn't have TTP, but this is moving on to thinking more about the combination of thrombosis and thrombocytopenia and what else that can be. So this was a 37-year-old lady who was 11 months postpartum, and she came to the emergency department with malaise and fevers, and she'd started to develop abdominal pain. And she had a thrombocytopenia on her initial full blood count, but the rest of her FBC at this stage was normal. So she had a blood film, there was no fragmentation, so that made us less worried about MAHA. And what I would say is, in general, for a presentation of TTP, we would usually expect a lower platelet count than 51. So we didn't think this was MAHA. And she had some reactive changes to her neutrophils, so we were thinking possibly she had an infection of some sort. Her initial coagulation profile showed a slight prolongation in her prothrombin ratio, a very high D-dimer and a low fibrinogen. So this started to make us think, is there some sort of consumptive process going on to explain that low fibrinogen and the very high D-dimer? And then when she had biochemistry done, she had an increase in her ALT and a slight elevation in CRP. So overall, we've got a young, fit woman who's nearly a year postpartum with a short history of low platelets with some features of DIC or consumptive coagulopathy and not obviously currently septic. So we thought, well, what shall we do next? And again, we're very fortunate in that it's quite easy for us to get imaging in this scenario. So we decided to do imaging. And when she had a CT of her thorax, abdomen and pelvis, she had quite a significant pancreatic inflammation, suggestion of thrombosis in the portal vein and mild splenomegaly. And then she went on to have confirmation of a portal vein thrombosis on alternative imaging. So people were thinking perhaps she's had cholecystitis that's caused the portal vein thrombosis. Or maybe she's had pancreatitis. So because of this, she was given a prophylactic dose of enoxaparin. That was a compromise because of the fibrinogen and the platelet count, with a plan to then escalate to full dose therapeutic enoxaparin the next day. After a couple of days, she suddenly became much more unwell and went to our intensive care unit. She had a raised lactate and she had further imaging, and she had a stroke, essentially, so right middle cerebral artery infarct, and extensive mesenteric thrombosis, so hepatic and splenic infarction. And she went on to have an emergency small bowel resection because of the degree of that, and didn't have any bleeding at the time of the surgery, despite having the low platelets and low fibrinogen. She came back to ITU and was given a big dose of steroids because we thought there might be an autoimmune component to this, and was also put on IV heparin. And then she went on to have other investigations, and one of the investigations she had was a HIT screen. So this is looking for anti-PF4 antibodies, and this was strongly positive. We know that the initial testing we do for HIT is often negative outside of the context of conventional HIT. So this test was done by a traditional ELISA methodology. And unfortunately, at that point, we decided that she should have plasma exchange because we suspected an autoimmune problem, but she had a cardiac arrest while that was being established, and ultimately died. And there was a feeling that perhaps she'd had a PE, or perhaps there was myocardial ischemia that had caused this. So this lady, her husband has done a lot of awareness work since her death about peripartum deaths and about how we could have looked at this differently, and the fact that the thrombocytopenia in the presence of the high D-dimer would make us think about this particular anti-PF4 condition in the future. So we know that HIT is a problem where we have autoimmunity against PF4, which happens when there's exposure to heparin. And people have then gone on to describe HIT-like syndromes in people who haven't had heparin exposure. So this is a case presentation of a similar disorder that resembled HIT but was felt to be spontaneous. And these authors about 6 or 7 years ago said that IVIG may be a good treatment option. And then when COVID hit, we started to see cases where people had had the COVID vaccine and then had this condition that we referred to as VIT, which was due to autoimmunity to PF4 as well. And we saw a particular preponderance of that condition for the cerebral veins. So with VIT, what we thought was that there was exposure to PF4 after people had had the vaccine, development of these antibodies, and then development of thrombosis. And this is one of my patients and his wife. So Jamie, my patient, is happy for his details to be shared and has done a lot of awareness work. So he had the AstraZeneca COVID vaccine. and then had VIT with presentation of a very, very big cerebral venous sinus thrombosis that was really disabling. I called his wife in several times to say that I thought that he would die of his condition, but he did survive. He had a cranioplasty because of raised intracranial pressure, but it's had a massive impact on his life, and he has been left, unfortunately, with some long-term neurological problems, although has done much, much better than any of us thought. And he and his wife have given evidence as part of the COVID inquiry in the UK, when thinking about the vaccination complications, although clearly the vaccine scheme overall was a very good thing in terms of public health overall. So we've then gone on to see cases of this syndrome associated with adenovirus. And ultimately, the lady that I've just presented, the feeling was that it may have been due to acute CMV, because we got some test results back after her death that suggested she may have had that. So I think this is a much rarer situation, but the presentation of thrombosis and thrombocytopenia in the presence of features of consumption, so a low fibrinogen and high D-dimer, does make us think now about whether there might be an autoimmune PF4 disorder. And we would then think about treating that with plasma exchange and with steroids. And we generally avoid heparin in these cases because we think sometimes that may potentiate this response, but that's an area where there's a lot of ongoing research. That's the end of the slides that I